Hello and welcome to part 2 of the special senses video. This video is going to be focusing on hearing and balance. And as you can see from this visual I put together to start off our slides, we have down here the inner ear. The inner ear is going to contain structures for interpreting the sense of sound as well as the sense of balance, or the vestibular sense. So we've got the inner ear here working as the fulcrum, or the balance point, and it's balancing both hearing, represented by the pinna or the external ear, as well as a gymnast here who is showing very great balance. Now, I'm not going to repeat a lot of the stuff that was covered in the lab. The lab went into pretty good depth into structures of the ear. You will be responsible for the structures in the ear that were discussed in the lab, so please make sure you go back over those. I'm going to touch on a few structures that are especially important to the senses of hearing and balance, though. Okay, and the three main parts are the external ear, the middle ear, and then finally the inner ear. So I'm going to skip over where we're talking about the pinna, or external portion of the ear that's going to act as the funnel for helping to bring sounds inward. I'm also going to skip over talking about the external auditory meatus, which is the canal that's going to be bringing the sounds to this area right here, which is where we begin our story, which is the tympanic membrane. So the tympanic membrane is going to be our boundary between the external and our middle ears. And it's going to be this membranous piece of connective tissue that's going to vibrate in response to sound. Perhaps you've been in a car and the person in the car next to you drives up with the volume turned way up and a lot of bass, and you felt the vibrations in your car, maybe your windows. We'll talk a little bit later about sound being vibrations, high pressure areas and low pressure areas in our air. Well, just like we can have sound vibrating the windows in our car, sound is going to be vibrating our tympanic membrane. As the tympanic membrane vibrates, it's going to be passing those vibrations onto the ear ossicles, and from the ear ossicles, those vibrations will be brought to the inner ear. This is a neat picture that's showing the tympanic membrane right here, as well as the three ear ossicles. So we've got the malleus, or the hammer, that we see right here. It's going to take the vibrations from the tympanic membrane and apply those to the incus, or the anvil. The incus is going to be applying those vibrations to the stapes, or the stirrup here. The stapes is then going to fit into an oval-shaped depression in the temporal bone called the oval window, which then brings the vibrations into the inner ear here, the vestibule, and then finally into the cochlea. It is interesting to know that the malleus is roughly hammer-shaped and the incus is roughly anvil-shaped. And I know not everybody knows what an anvil is, so here's a picture of an anvil. An anvil is a structure used for beating on metal, especially hot metal when you're trying to shape something. So the hammer, or the malleus, is going to be impacting on the incus right here, transferring vibrations. The vibrations then go from the incus to the stapes to the inner ear. So our middle ear is going to be this air-filled space that's going to be between the tympanic membrane and the inner ear. It's going to contain the ear ossicles, which we just discussed. And it's also going to contain the pharyngotympanic tubes. Now, pharyngotympanic tubes are also sometimes called the auditory tubes, or the eustachian tubes. And their job is to help connect the middle ear to the pharynx, or that tube in your throat that's going to be connecting your nasal cavity to the rest of your digestive and respiratory tract. If you've ever gone up in an elevator, if you've ever been in an airplane that's going up, you feel this pressure build up. Well, perhaps you've grabbed your nose and given it a blow. That's called the Valsalva maneuver. And essentially what you're doing when you're doing that is you're forcing air through the eustachian tube that you see here, and that allows you to equalize the pressure both in your middle ear and in the outside. This is particularly important to people who get chronic middle ear infections. So the proper term for middle ear infection is otitis media. Itis, hopefully by now you know, means inflammation. Otic means ear. Media means middle. So otitis media literally means a middle ear infection right here. And as with most parts of the body, when you get an infection, it's going to cause inflammation. It's going to cause you to send lots of leukocytes to the area to help fight off the pathogen. Now, normally, the byproducts of the fight of an infection is going to be pus. Normally, pus would drain out through the pharyngotympanic tube that you see right here, and everything would be okay. But some people have chronic blockages or a decrease in the size of the pharyngotympanic tube right here. And as a result, they end up with lots of pressure inside of the middle ear. That pus is going to be pushing on the tympanic membrane. And your tympanic membrane has lots of nerve endings. And that can be extraordinarily painful, middle ear infections. So when that happens, sometimes surgery is done to open up a little hole in the tympanic membrane and allow that pus to drain out. Perhaps you've heard of people having ear tubes put in. So the surgery is called a myringotomy, and sometimes they put in the tubes to open up the hole, sometimes they don't. But let's take a look at a couple of short myringotomies and get a better idea of what's going on. So I've already brought this up, and we will see it here. By the way, you can get this, the URLs for these will be in the notes, the PowerPoint notes.
Dr. Efrat, today we'll discuss and visualize a myringotomy performed in the office. Myringotomy is otherwise known as an eardrum puncture. This is sometimes done due to buildup of fluid in the middle ear, severe ear infection that doesn't respond to antibiotics, chronic fluid resulting in hearing loss, and sometimes we'll do this prior to air travel and getting on an airplane with patients who have middle ear fluid or infection. This actually protects the ear during the pressure change of air travel. So the first part of performing the procedure is examining the patient's ear. Here we illustrate a normal eardrum. It is clear and translucent. There's no evidence of redness or fluid behind the eardrum.
So I'm going to stop this for just a second, and I'm going to move back just a little. In order to get this picture, they put this tiny little camera into the external auditory meatus so that they can visualize the tympanic membrane. Now you can actually see the malleus behind the tympanic membrane. Here's the tympanic membrane. You can see the malleus here, which is pretty cool. You can also see a little bit of earwax building up. That's what this is.
Fluid behind the eardrum. However, when you compare it to this eardrum, you can see amber yellowish fluid behind the drum, creating a meniscus or an air fluid level. So the first step involves anesthesia, and we use topical anesthesia on a special Q-tip type device. This is topical phenol, which creates a whitish discoloration to the eardrum once applied. This does burn upon application, and this is performed while the patient is awake in the office. Next, the myringotomy blade is used to make an incision in the eardrum. This is the anterior part of the eardrum. You can see the blade, and we make the incision parallel to the fibers of the eardrum.
Isn't that cool?
You can see the middle ear fluid starting to extrude out of the eardrum puncture that we've created. Next, we need to remove the middle ear fluid. This is performed with a suction device, and you can see the middle ear fluid being removed. Once this is done, there is immediate relief and the patient's hearing is restored. once we are done, you'll see that a 0-degree telescope is used to enter the middle ear space, and you can see the redness and inflammation of the lining of the middle ear due to the infection.
So you're actually going through the tympanic membrane.
Procedure. The patient is now placed on antibiotic ear drops for approximately 1 week, and the incision will heal spontaneously.
So that was kind of a neat video. I do have one more that's also showing the putting in of a ear tube. So let's look at this one.
This is François Simon, pediatric ENT at Necker Hospital in Paris. This is a how I do it video showing shepherd ventilation tube insertion in OME. In this right ear, we can see typical retrotympanic fluid and chronic inflammation. A linear radial myringotomy is performed in the anterior-inferior quadrant. Okay,
so just so you know, this person would be under general anesthesia, so you wouldn't want to be doing this on a person who was fully conscious. It would be very painful.
To avoid any ossicle injury, this must be just large enough to insert the ventilation tube. Take great care when manipulating instruments so as not to injure the anterior canal wall, causing bleeding.
That's pus coming out.
Effusion is suctioned, especially if it hinders the ventilation tube placement. Take care not to use a too large suction so as not to induce sound trauma. The tube is inserted using microforceps, firmly holding the shepherd with a 90-degree angle. The anterior flange is directly inserted in the myringotomy, and the posterior flange is clipped down by lowering the forceps. The same is performed in the left ear. First, dead skin and cerumen is removed.
Remember cerumen earwax?
The eardrum is often thick in OME, and you must be careful to cut through the entire thickness and not just the superficial layers. On the contrary, do not insert the instrument too deeply, as the inflamed mucosa can easily bleed and hinder tube insertion. Effusion is suctioned. Once again, the shepherd tube is inserted anteriorly. The posterior flange is clipped with the forceps, but it can also be pushed in using a needle or a hook.
Pretty cool. Okay. So I do have the links to both of these if you would like to watch them on your own. It is pretty cool stuff. So the ear ossicles we mentioned are the malleus, the incus, and the stapes. And their job is to transmit vibrations from the tympanic membrane to the oval window, which is the depression in the temporal bone that leads to the vestibule of the inner ear. So the parts of our inner ear, labyrinth is kind of the general, kind of old-fashioned term that we use for inner ear. I bring it up because we'll talk about some disorders later that might cause labyrinthitis or inflammation in the labyrinth or inner ear. Breaking down the labyrinth or inner ear, we've got two parts. We've got the bony labyrinth and we've got the membranous labyrinth. The bony labyrinth is going to be the more superficial part of our structures, the semicircular canals, the vestibule, and the cochlea. And these are in contact with the temporal bone. That's why we call it the bony labyrinth. And these are also filled with a fluid called perilymph, peri meaning around. So it's going to be the more superficial part of the inner ear. And perilymph chemically is going to be very similar to cerebrospinal fluid. The next part of our inner ear is going to be called the membranous labyrinth. These are going to be the membranous sacs that are deep to the bony labyrinth. And we talk about these because they're filled with a different fluid called endolymph that is similar in chemical composition to intracellular fluid. So here's a nice close-up of the inner ear. And I really like how this one is colored. Where it's colored in purple, that represents the bony labyrinth that's covered in perilymph. And where it's colored blue, this is going to represent the membranous labyrinth, which is going to be filled with endolymph. All right, so other parts of the internal ear are going to be the vestibule, the semicircular canals, and the cochlea. So this is going to be the vestibule right here. And the vestibule, if you think of it like the vestibule of a building, it's where you walk in, and from here you go to the different places. There's also two depressions in the vestibule here. We've got the oval window, which is going to be the depression that the stapes is going to be articulating with to bring sound in. We also have this area right here called the round window. This is going to be where sound waves that were not used for generating action potentials leave the inner ear so that they're not disturbing any incoming sound vibrations. So we've got our vestibule here. We've got these structures right here, which are our semicircular canals. And then we've got this snail shell shaped structure here, try to say that 5 times fast, which is called our cochlea. So the vestibule is going to be the central cavity of our membranous labyrinth. And a vestibule is going to contain 2 sacs. The first of which is called the saccule, which literally means little sac. And that's going to be continuous with the cochlear duct. So if here is our vestibule right here, the saccule is this area right here that's going to be closer to the cochlea. And then the utricle is the little sac that you're going to see right here, which is closer to the semicircular canals. Both the saccule and the utricle are important because they're going to contain equilibrium receptors called maculae. Macula would be singular. And the maculae of the saccule and the utricle are for interpreting the sense of linear motion. So, and to be honest with you, I'm not going to test you on which direction the saccule and which direction the utricle is for detecting, but I do want you to know in general that these are for linear motion. So the utricle is responsible for detecting movement in the horizontal plane or the tilting of your head. So if you are in a car, and I don't recommend this because it's not safe, but if the light turns green and there's nobody around and you press down on the accelerator really fast and you have that feeling of being thrown back, hey, that linear motion is what's going to be detected in the utricle, in the horizontal plane. The saccule is what you're going to feel when you get in an elevator, and if that elevator is going up really fast, or if you get in the airplane and the airplane starts to rise really fast. Those sensations are generated by the saccule. So here's a neat picture that shows in our inner ear, here's the saccule and here is the utricle, and they've actually cut into the utricle here, and they're showing this structure here, which is a single macula. Don't forget, put the E on it to make it plural. Well, inside we've got a number of cells here, and we've got a membrane that has what are called otoliths. And otoliths I'm not going to expect you to know, but essentially they are little bony structures that are embedded in the membrane, give it more mass. Don't forget, this is going to be filled with endolymph, that the fluid in the membranous labyrinth. Now, when that car is accelerating and you're feeling yourself being thrown backwards, or in the case of this person here, when he is tilting his head forward, that's going to cause the endolymph to slosh around a little bit. As that endolymph sloshes around a little bit, it's going to cause this membrane to bend. Now look what happens here. These structures are called hair cells, and the little hair-like structures coming off of them are called stereocilia. When the membrane here moves as a result of the head moving, or the body moving in the case of the car taking off, that's going to cause this membrane to move, and that's going to bend the hair cells. Bending the hair cells generates, ready for this? Action potentials. And those action potentials are then going to travel out through the rest of the sensory neuron here and eventually make their way to the brain so that you're sensing that something is happening in 3 dimensions. So the maculae are these structures that you're going to find in the saccule and the utricle for linear motion. Our semicircular canals are those 3 canals that are in the inner ear. And there are, as the says up above, there's 3 of them. So there's one that's oriented anteriorly, one that's oriented laterally, and one that's oriented posteriorly. These are going to communicate with the utricle, meaning that endolymph is going to flow between the utricle and the semicircular canals here. And there's going to be a similar structure in the semicircular canals to the macula, and these are called crista ampullaris. And the equilibrium receptors in the semicircular canals are the crista ampullaris. And these are going to respond to angular or rotational movements of the head. So here is our ampulla. It looks pretty similar to the macula that we saw before. Not going to have so much of a membrane though, but we certainly have these hair cells with the stereocilia sticking up. Now don't forget, don't mix up. The cells are called hair cells. The hair-like structures coming out of them are stereocilia. And when you rotate your head to one side, that's going to cause the endolymph to slosh around. It's going to bend the structure here in the ampulla, bending the hair cells and generating action potentials. Now, perhaps you've done this before. You've gotten in a chair or you've gotten on an amusement park ride and you spin around and around and around and around and you stop. And even though you know you have stopped, you know you are not spinning around anymore, you still feel like you're spinning. Okay, the reason why you still have that sensation of spinning is because the endolymph in your semicircular canals is sloshing around inside the semicircular canals. The fluid is still moving. As that fluid moves, it's going to be bending back and forth the stereocilia here. So part of you will think that you're still moving when you really aren't. Next structure is going to be the cochlea. Now, cochlea is taken from the Latin and, in fact, Spanish word for snail. So the cochlea is a snail shell shaped structure. It's another thing you should say 10 times fast. Snail shell shaped structure. It's going to be attached to the vestibule, and it's within the cochlea that we will detect the sense of hearing. So within the cochlea, we're going to find structures called spiral organs, or in the old-fashioned days when we used to name things after people, we called this the organ of Corti. What are we going to find in the spiral organ? Well, guess what? Hair cells that have those projections called stereocilia coming out of them. So when sound waves are going to be transmitted into the endolymph of the spiral organ, that's going to cause some of those hair cells to bend. And when those hair cells bend, they're going to generate action potentials, which when they get to the brain, traveling along the vestibulocochlear nerve, remember that one? That can be interpreted as sound. So here's a neat video. It's kind of showing the pathway here that I will show you.
Activity for the detection of
Whoa,
different tones.
how about we start this from the beginning?
Ears are constantly active. They pick up sound waves and change them into information that the brain can interpret, such as music or speech. Sound is a pressure wave that can vibrate either quickly or slowly. Slow vibrations produce deep sounds, while quick vibrations produce high-pitched sounds. Sound enters the ear and is directed through the ear canal, where it first reaches the eardrum. As the eardrum begins to vibrate,
Tympanic membrane.
sets the ossicular chain in motion. The ossicular chain consists of the hammer, anvil, and the stirrup.
Now, something kind of interesting that I forgot to mention. The fact that we've got the tympanic membrane here vibrating the ossicles, the way these ossicles are set up, they actually amplify the sound. So they increase the strength of the vibrations being brought to the inner ear.
Sound vibrations move along the ossicular chain and into the inner ear. Within the inner ear, the cochlea plays a central role. It is here that the mechanical energy of sound is converted into complex electrical signals, which are then passed on to the brain. In simplified terms, the cochlea is a spiral-shaped tube filled with fluid.
Endolymph.
Sensory cells, also called hair cells, line the entire length of the cochlea. These hair cells have varying degrees of sensitivity for the detection of different tones or frequencies. This allows the ear to perceive the entire spectrum of sound. The change from mechanical vibration to electrical pulse is a complex process resulting from the movement of hair cells in the cochlea. Along the entire length of the cochlea, the hair cells are arranged like the keys of a piano.
So what this is showing here, and we'll talk about this in a little while, we're looking at the different pitches of sound. And we measure pitch in cycles per second, which is called hertz. So the highest pitches sounds, which are around 20,000 hertz, the hair cells that are sensitive to those are going to be the more proximal portion of the cochlea. Now, even though this is shaped like a snail shell, really what it is this great big long tube that's been rolled up onto itself. So as sound waves are going to be traveling into this tube, different pitches, so different wavelengths of sound are going to be detected by hair cells that are sensitive to those different pitches. So that by the time we get close to the end of this part of the tube, we would have our lowest pitch sounds that we're able to hear.
Hair cells located at the base or lower region of the cochlea are responsible for high frequency, while hair cells at the apex are responsible for the low frequencies. As the fluid in the cochlea is set in motion, it causes a corresponding movement of the fine structures on the surface of the hair cells to take place. These movements cause tension differences, which produce electrical signals that are passed along the hearing nerve to the brain. The auditory cortex of the brain interprets this information as sound, for example, as music or speech. The entire chain of events, including the various steps that convert sound waves from the environment into information that the brain can interpret, happens so fast that individuals can hear sound both continuously and instantaneously. Within this complex chain of events, there are a number of factors which can cause an individual to experience hearing loss. A loss of hearing can range from a mild to moderate hearing deficiency to a total hearing loss. In general, there are three main types of hearing loss which differ from one another depending on the part of the ear that is affected, be it the outer, middle, or inner ear.
Okay. So, we're talking about the inner ear. In particular, we're talking about the cochlea. Now, interesting thing, I said that the cochlea is this one great big long tube that's been rolled up. That's a little bit of simplification, because within the cochlea, we've actually got three tubes. So I really like this picture. You can see inner ear here, and this is the unrolled version of the tube. Sound being brought to the cochlea here, you can see the oval windows, so this is where the stapes articulates. Sounds are brought into this part of the tube, which is called the scala vestibuli, and I believe they call it vestibuli because it's close to the vestibule of the inner ear. So as sound is traveling through the scala vestibuli here, when it reaches an area where this inner tube, called the scala media, has hair cells that are sensitive to a particular vibration. Those vibrations then travel into the cochlear duct, or the scala media here, where they generate action potentials. Now, if a person has hearing loss, or if the vibrations are either lower than 20 hertz or higher than 20,000 hertz, those vibrations make it all the way through this tube, the scala vestibuli, and then here's the apex that we just talked about in the video, and then really the scala tympani is just a continuation of that original tube where we're bringing the sound out of the inner ear through the round window where it can then go out the pharyngotympanic tube. Okay, I'm using this to introduce the fact that we have within the cochlea those three different tubes. So again, the scala vestibuli is going to be the portion that's going to touch the oval window, and this is going to contain perilymph. So this is where sound is coming into the ear, or into the cochleas through the scala vestibuli. The cochlear duct, which is also called the scala media, that's going to be that center portion in the cochlea, and that's going to be filled with endolymph. And it is within the endolymph that we're going to have the spiral organ, or that organ of Corti, which is where we have the hair cells that are used for detecting sound. And then the scala tympani is going to be really the continuation of the scala vestibuli for bringing vibrations out of the cochlea so that it doesn't interfere with new vibrations coming in. And both the scala tympani and the scala vestibuli connect at that area called the helicotrema or apex. Please do note this isn't a spelling. Scala with an E is scali, is just the plural form of scala. And then in between the scala tympani and the scala vestibuli will be the cochlear duct. And here you can see it again. So sound is going to be coming in the scala vestibuli, reaches the apex, will be leaving through the scala tympani, and here is the cochlear duct or the scala media. More commonly called the cochlear duct nowadays, but I learned it as the scala media. This is a neat picture. This is showing a cross section through the cochlea. So a cross section was made here. So you can see they call it the upper canal. This was taken from a little lower level of a book. Upper canal is the scala vestibuli. I would prefer that you call it scala vestibuli. What they call the lower canal here, I would prefer that you call it the scala tympani. And then this tube right here, in which case, where we're going to have the organ of Corti, is the scala media or the cochlear duct. Okay, and this is kind of cool here. It's showing the oval window for bringing sound into the cochlea, and the round window by the time sound gets all the way up to the helicotrema or the apex here, it's then going to be going out. And those sound waves go, oops, I moved it here. Sound waves going out will then go out through the round window. Here we see a magnification of the cochlear duct right here. And you can see pretty clearly here are our hair cells with the stereocilia sticking up off of them. And this structure that the stereocilia are embedded in is called the tectorial membrane. Really what's going to be happening here is when sound is brought in through the scala vestibuli, and let's say this is the part of the cochlea that is hair cells tuned to be activated by sound at this particular wavelength. Those vibrations will then travel in, will vibrate the tectorial membrane here. When the tectorial membrane vibrates, it's going to bend the hair cells, or excuse me, it's going to bend the stereocilia, and that's going to cause action potentials in the hair cells, which then make their way to the brain. And there's our spiral organ, or our organ of Corti. All right, so the transmission of sound to the internal ear. Now, I used to ask this as an essay question, and aren't you lucky that I said I wouldn't put any essay questions on the final? Okay, so I won't make this as a possible essay question, but this would be something good for you to know for the final. Hint, hint, hint. Okay, so transmission of sound in the internal ear. Number one, sound waves are going to vibrate the tympanic membrane. That's going to cause the ossicles to vibrate, and as I said, that amplifies the pressure, the vibrations being brought to the oval window. Those pressure waves are then going to move through the perilymph to the scala vestibuli, that tube in the cochlea bringing sound in. Sounds that are within the hearing range, so between 20 hertz and 20,000 hertz, are going to go through the cochlear duct or the scala media. From there, they're going to vibrate that tectorial membrane at a particular location, keeping in mind that different parts of the cochlear duct have hair cells that are sensitive to different wavelengths. So the moving of the tectorial membrane is going to bend the stereocilia of those hair cells, and that's going to open up gated potassium and calcium ion channels, so a little different from our action potentials from before, but the same general idea. The flooding in of ions is going to generate an action potential. Action potentials are then going to move along the cochlear branch of the vestibulocochlear nerve on the way to the brain. So here we see our inner ear. So this would be our oval window. Vibrations are brought in this way. We would see sound traveling through the scala vestibuli here. And when it reaches the area that's sensitive to that particular wavelength, the vibrations move into the cochlear duct or the scala media, generating action potentials there. Those action potentials are then going to travel out through the cochlear branch of the vestibulocochlear nerve. Something I forgot to mention before, here you can see some of the macula here and how they're attached to the vestibular branch of the vestibulocochlear nerve. So that's why we say for this cranial nerve, it's going to be carrying information for balance and hearing. Oh, and I did forget to mention, so any sound waves that are not going to be used for hearing then travel out the scala tympani and then out the round window so that it doesn't interfere with any incoming sound waves. So properties of sound. Sound represents a pressure disturbance. So alternating areas of high pressure, so packing a bunch of air molecules together, and then areas of lower pressure where those molecules are spaced a little bit farther apart, and that's produced by a vibrating object. And if you've ever looked at a speaker when the speaker is working, you can see the membrane of the speaker moving. And literally what it's happening is as that speaker is moving out, it is pushing air molecules. And that area of high pressure of air molecules followed by the lower pressure, the vibrations from that we will perceive as sound. Now, unless there's something directing where sound is going, those vibrations move out in all directions, and we could graph the pressure waves as an S-shaped curve or a sine wave. And I'll show you some of those in a moment. So frequency represents the number of waves that are going to pass a given point in a particular amount of time. We usually measure frequency in the numbers of cycles per second. So the top of one wave to the top of the next wave is one cycle. So the number of those cycles per second is hertz. That's our measurement of frequency. So when we say sound at 20 hertz is at the low end, the low pitch, literally we're going to have 20 of those cycles from point to point. Sound waves at 20,000 hertz literally will have 20,000 of those cycles in 1 second. Okay, and we perceive sounds at different wavelengths as different pitches. So here I have drawn a couple of waves. Now notice that they go the same distance. From here to here in red is the same as from here to here in green. But notice in red, the top of this wave and the top of this wave are farther apart than the top of the green wave here to the top of the next green wave. Okay, so um, in 1 second, we would have fewer of these waves. So a shorter frequency we would perceive as having a lower pitch. Okay, because in 1 second we would have more of these waves, we say it has a higher frequency and it has a higher pitch, or we would perceive it as having a higher pitch. And then wavelength represents the measurement of the distance between the top of two crests of the waves. So if we wanted to measure wavelength, here we see a speaker, and this speaker is generating sound, and when the membrane pushes out, all these little dots represent air molecules. So as it pushes out, we've got this wave of high pressure air, and then lower pressure air as the membrane goes back, and then another wave of high pressure air, and then lower pressure air. And our ear is going to perceive that high pressure and low pressure, our hearing mechanism, as sound. And here you can see what I'm talking about in terms of measurement of wavelength. So the top of one wave to the top of the next is how we measure wavelength. And we can look at wavelength as a measurement of pitch. We could also do that with frequency, because the shorter the wavelength, the greater the frequency would be. So pitch is how we perceive sound. Okay, remember, sound technically represents those areas of high pressure and lower pressure sound, but when those higher pressure and lower pressure air, by the time those pressure waves make their way to the cochlea, they're generating action potentials, and where our brain interprets those action potentials, we perceive those sounds as being at different pitches. Our normal hearing range is between around 20 hertz and 20,000 hertz, although this can certainly change as we get older. We lose the ability to hear some of the higher pitches in many people. With remembering that the higher the frequency, the higher the pitch is going to be. Amplitude represents the height of the crests, and loudness represents our interpretation of amplitude. So normal range of hearing is between 0 decibels, which is no sound, and 120 decibels, decibels being the term that we use for measuring amplitude. There's a really nice video I'm going to show you in just a moment that kind of puts all these different pieces together. But I want to show you this. So here's another one of our sine waves here. A higher amplitude, so something that we would perceive as being louder, is what we see here with the red wave, and a lower amplitude being quieter is represented by the blue wave here. So let's look at the last video I'm going to show you, which is right here. I like this guy.
Hey, what's up? It's Wick for Wikimedia Tutorials, and this season we're taking a look at spectral processors. So to really understand EQ, this episode we're going to take a look at frequencies. To get a better understanding, I'm going to use a sine wave as an example. The sine wave is the purest and simplest form of sound, and it's not found in nature, but it's really helpful when it comes down to explaining frequencies. When this sine oscillates 360 degrees and makes a completed cycle, that's what we call a full cycle. The amount of completed cycles that fit in 1 second is what we call the frequency. Higher frequencies can go up to 20,000 completed cycles per second, or 20,000 hertz, which we call 20 kilohertz. We can divide our groups of frequencies simply in two groups, low frequencies and high frequencies. Low frequencies are called bass and high frequencies are called treble. The frequency range of the human ear ranges from 20 hertz up to 20 kilohertz. We do lose some of our hearing capabilities when we get older, that's why elder people can't hear higher frequencies. Let's listen to some sine waves so you get an idea of what they sound like. This is a 500 hertz sine wave. This is a 1000 hertz sine wave. This is a 5000 hertz sine wave. This is dropping from 1000 hertz to 75 hertz. These are pure sine waves, and they cannot be found in nature. But all sounds that are found in nature, like speech or any music-related sounds is a composition of various sine waves at different amplitudes. A concert A is tuned at 440 Hz. If we play that A note on a guitar or on a piano, it's the same note, but still we can hear that it's a piano or a guitar. That is because the fundamental frequency is 440 Hz, but the character of an instrument is determined by the harmonics. The harmonics make up the timbre, or the character of the sound, and that is different for a guitar than for a piano. The shape of the instrument, the way that the notes are being generated, like if they're being plucked, if they're being bowed, or if they're being finger picked, or being hit with hammers, and that all determines the way that it sounds. So the material that the instrument is being made out of, even the type of wood, can have influence on the way that it sounds. When we're working with audio, we're looking at the frequency content of a certain signal. Especially when we separately record different instruments for a mix, we can change the frequency content of each of these tracks that we have recorded. When we have a spectral analyzer or something which shows us the frequency content, we see on the horizontal axis our frequencies going from 20 Hz up to 20 kilohertz.
Okay, and I think that's helpful to us, but we don't need to go any more into that. All right, so this is a little something I put together to show in terms of decibels, which again is our measurement of amplitude. So something at around 30 decibels, which you see here in green, represents the loud as a whisper would be. 60 decibels represents a normal conversation with people. Vacuum cleaner is going to be around 75 decibels. Problems can occur if people are exposed to sounds over 80 decibels for long periods of time. So we've got about 85 decibels here being your typical lawnmower. Chainsaw or snowmobiles can go around 110 decibels. If you're at a sports stadium or a concert, they can regularly get over 125 decibels. And being within around 100 feet of a siren or a gunshot can be up to 140 decibels, sometimes even more. So again, you want to be careful over 80. You want to be protecting your hearing. All right, so auditory processing. Hang in there, we're almost done. So impulses from specific hair cells are interpreted as different pitches. So if we see a hair cell that's close to the opening of the cochlea, remember those detect their highest pitches. If we then have a hair cell that's halfway down the cochlea, sending an action potential, the brain, the auditory cortex of our brain, can interpret those action potentials as representing different pitches. Loudness is detected by increasing the number of action potentials by activating more hair cells. Okay, so something that is really quiet might only be activating a small percentage of the hair cells, whereas something that's really loud is going to be activating a greater percentage of the hair cells. And then perhaps you've noticed that we can tell where sounds are coming from. So if you were to close your eyes, and you're just hearing me now, so that probably doesn't help. But later on, I want you to go where there's other people and other stuff going on, and I want you to close your eyes, and you can tell if sound is coming from your right side or sound is coming from your left side. And the reason for that is you have two ears. And if the sound is generated over here, the sound is going to be detected by your left ear a fraction of a second before your right ear does. So our brain can interpret the difference in receiving those sounds as being able to figure out where those sounds are coming from. And when you think about it, that's a pretty good evolutionary advantage. If you're looking for food or if you're trying to avoid predators, knowing where those things are is a good idea. Okay, some homeostatic imbalances associated with hearing. First one we'll talk about is conduction deafness. And as the name implies, this is deafness that occurs as a result of a problem with conducting sound waves into the cochlea. Okay, this could be from having impacted earwax, could occur as a result of perforated eardrum, Could occur as a result of otosclerosis, where we're having abnormal growth on those ossicles. You can also have sensorineural deafness, where deafness is occurring as a result of something in the neural pathway, from the hair cells to the auditory cortex of your brain. Something is not functioning properly, so those action potentials are not being generated, transmitted, or interpreted. We can also talk about tinnitus. Tinnitus is the term that means a ringing or clicking in the ears in the absence of auditory stimulus. So something, someone is perceiving these ringing or clicking sounds when there is not sound actually being generated. This can occur as a result of degeneration in the cochlear nerve, inflammation in the middle or internal ears. Aspirin and some other drugs can lead to tinnitus too, so lots of different causes. And this is, for many people, maddening. It drives them kind of crazy. And there are some therapies and some drugs that do help with this to some degree. And then the last of the homeostatic imbalances we're going to talk about is called Meniere's syndrome. Meniere's syndrome occurs when there's too much endolymph building up pressure in the cochlea and in the semicircular canals. Kind of like, what's that disorder that we talked about in the eye where we have too much pressure? Glaucoma. So Meniere's syndrome is kind of like that. And the problem with Meniere's syndrome, it can cause tinnitus, it can lead to hearing loss, but it can also lead to problems with vertigo and nausea and vomiting as a result of the vertigo and nausea. So this one isn't a lot of fun, I am told. Ladies and gentlemen, do you have any questions? Do you have any problems? Do you have any difficulties? You have reached the end of the lecture notes for Biology 244. Thank you for all of your hard work. Now study hard for the final and make me proud. Give yourselves a round of applause. Woo! Take care, everybody.